So good evening, everyone, and thank you all for being with us tonight. This is the third night of Brain Health Awareness Week, and if you missed the first two nights dedicated to learning about ways we can keep our memory sharp throughout life and solving the Parkinson's disease puzzle, you can still see these videos on the links on our website. So again, to introduce myself, I'm Ruth Slack, the director of the University of Ottawa Brain and Mind Research Institute. And it's a pleasure to introduce the Brain and Mind team who worked very hard to put on the event for the entire week. So I'd like to introduce Natasha Hollywood, our program manager.
Je vous souhaite la bienvenue.
Victoria Rache, our communications coordinator.
Hi there.
And Candice Fortier, our administration coordinator. So on behalf of the entire team, I would like to extend a warm welcome to all of you tonight. So tonight's session is entitled Your Brain on Exercise and Why It Matters. And I'm sure we all know all about the health benefits of exercise, but you may not be aware that exercise has a major impact on brain health, including mental health, recovery from injury, memory, and cognition. So tonight we will hear from our experts about the benefits of exercise and how it impacts the brain. So we'll hear from doctors Andrée-Anne Ledoux on post-concussion recovery, Dr. Natalia Jaworska on exercise and mental health, and Dr. Amy Xu on exercise and how this can reduce the risk for dementia. So to begin our session, it's a real pleasure to introduce our first speaker, Dr. Andrée-Anne Ledoux, who is an assistant professor in the Department of Cellular and Molecular Medicine at the University of Ottawa. She is a scientist at the CHIO Research Institute and a member of the University of Ottawa Brain and Mind Research Institute. And she'll be talking about exercise and post-concussion recovery. So welcome, Dr. Ledoux.
All right, good evening, everyone. It is my pleasure to be here tonight to discuss pediatric concussion and management. As some might be aware, concussion can occur to anyone, and understanding and recognizing the signs and symptoms and how they are managed plays a key role in prevention of more serious injuries. Oops. So our learning objectives for today is to understand what is a concussion, and we'll as well examine the association between early physical activity and prolonged recovery risk. And at the end of the presentation, if we still have time, we will discuss guidelines and strategies on how to return to play and life. And if we don't have time during the presentation, perhaps this is something we can discuss over the questioning period. So the Center for Disease Control and Prevention refers to concussion as a silent epidemic because there are numerous cases of concussion that go unreported each year. And this is principally due to the fact that the symptoms are not visible. 1 in 2 Canadians have little or no knowledge about concussion, and 1 in 4 do not know how a concussion is even being treated. So how do we treat a concussion? Unintentional injuries are the leading cause of death, hospitalization, and disability among Canadians and among Americans as well. And of these concussions are actually among the most common. In 2013, over 35,000 pediatric concussions were reported in Ontario, which is quite a significant amount. And from 2003, as we can see in this screen right here, so from 2003 to 2013, visit rates per 100,000 children increased over 4-fold. So we are making progress at reporting, but unfortunately it is still underreported in Ontario and across Canada and across worldwide as well. So tonight I will be discussing physical activity and post-concussion symptom. But before, I would like to introduce 6 things that you should know about concussion. And afterwards I will lead into physical activity. So first of all, it's just really important to understand what is a concussion. So concussion is a brain injury. It is actually a mild traumatic brain injury. The injury is induced by a direct blow or indirect blow to the head, to the face, to the neck, or actually anywhere else on the body with an impulsive force transmitted to the head. So this means you actually don't need to get directly hit on the head to suffer from a concussion. And this injury will actually disrupt the normal functioning of the brain. And just to look a bit more in detail, what is a concussion? So when you have the blow of the jaw to the head, this can make your brain move through the cranium, shifting from one side to another, as seen in this little video right here. And during this motion of acceleration, deceleration of the brain, there needs to be as well rotational forces that are applied to the brain in order to have a diffuse brain injury. So during this rapid acceleration of the head, some parts of the brain can actually move separately from other parts, as seen in this video. And you're going to see on top of the part here of the brain, you can see that, and I'll just replay that as well. You can see that the frontal lobe has kind of actually separated, and so this stretching or this type of motion will create shear forces that can stretch or destroy the nerve bundles of the brain, and this will cause a diffuse brain injury. And so a concussion is a diffuse brain injury, and so these nerve bundles are necessary for brain functioning, and this type of injury will contribute to some of the cognitive disturbances that we see in concussion. And if we look at a microscopic level of a concussion, will produce a cascade of biological changes to the brain and can cause disruption to the mechanisms involved in regulating the cerebral blood flow. And just please remember what I just said, which will be involved in regulating cerebral blood flow. So there will be a disruption to the cerebral blood flow. All of these changes are at the basis of neurological impairments that we see in a concussion, and these impairments are often short-lived. However, in some cases might evolve over time. So a child's brain is not the same as an adult brain, and it's still developing. It takes about 21 years for a brain to mature, and therefore needs a unique approach in care when it comes to a concussion. Children actually will recuperate differently and more slowly than an adult. And just a fun, I guess, fact that most people are not aware of is that you can actually have a concussion without losing consciousness. And in fact, concussion signs and symptoms are more than just, physical. They can be mental, emotional, and behavioral. And if we just look a bit more in details, what are the symptoms and the signs of a concussion, or after you had an injury to the head? Well, these can be physical, so for instance, sensitivity to light or sensitivity to noise. They can be as well mental, such as feeling foggy, difficulty thinking, feeling slowed down, difficulty concentrating and remembering. You can also have sleep issues after having a concussion, so difficulty falling asleep or sleeping too much, sleeping not enough. And they can also be emotional and behavioral, so feeling irritable, nervousness, frustration, anger, and sadness. And these concussion symptoms can actually evolve over time. You can have one symptom after having your head injury, and over time, after 24 to 48 hours, you can have more than one symptom. And in most cases, concussion will actually resolve within 4 weeks. However, 30% of the pediatric population will have 3 or more symptoms that last longer than 4 weeks, and that can last for months to years after having their concussion. And this type of impairment, we call it persistent post-concussive symptom. And these persistent symptoms are the same as the concussion symptoms previously seen in the previous slide, so emotional, physical, mental, and sleep disturbances. But these symptoms will impact the life of the children, but will also impact the parent's life. And just to show you the impact of persistent post-concussive symptoms, in our lab, we compared the quality of life of participants with a concussion who had persistent post-concussive symptoms, which are in yellow right here in this graph, compared to those patients who did not have persistent post-concussive symptoms. And we start realizing that those kids that do have persistent post-concussive symptoms, it is harder for them to take part into activities because they have low energy. They miss school and activities more often. They have emotional impairments. They feel sad and angry more often. They have poor social quality of life. So for example, having trouble getting along with other kids. And finally, they have difficulty in school. They have difficulty paying attention and concentrating concentration. So overall, they have lower quality of life. And so finding a management intervention that can prevent persistent post-concussive symptoms, or that can actually manage the symptoms after having a concussion, becomes very essential. So what happens now? What happens after you have a concussion? How do we manage concussion, and how can we prevent persistent post-concussive symptoms? A still widely used practice is the advice of rest. Rest after having a concussion, and only starting back physical activity once completely symptom-free. This prescription of rest can do more harm than good, resulting in a sentence of bedroom jail. And so you can imagine that if even as an adult or as a child, you put someone in a room at home and say, well, you know what, you can't go to school, you can't go to work anymore, you can't do the sports that usually you do, or you can't go play at the park, you can't go outside because you need to rest. And until you are asymptomatic, until you have no more symptoms. And then afterwards, you can start back your normal routines. That can have a huge impact on the mental health of the individual. And so these rest guidelines come from the previous concussion protocols, where it was endorsed that children should avoid physical activity until completely symptom-free. Now, rest does play a role, but protracted physical rest may actually negatively impact concussion recovery. So creating more symptom or having prolonged symptoms, it can result in anxiety, depression, and physiological deconditioning. So the question comes, so why can't these kids just return, or these adults after a concussion just return to their routine, or progressively return to their routine, progressively return to physical activity? And because we know that there are physiological, psychological, and functional benefits of early physical rehabilitation, and these have been observed as well in other diseases, processes such as a stroke, which, you know what, that is a severe traumatic brain injury. After someone has a stroke and is in the hospital, 24 to 48 hours after having the stroke, often the rehab team is going to come and will want to rehabilitate this patient, and they will often use a physical activity. So physical activity, we know it improves mood, it improves sleep, it improves cognition, it improves academic achievement in kids. It also improves cerebrovascular regulation, and it will increase as well what we call neurotrophic factors. These are proteins that are there to help repair your brain. And so, for instance, they can help in neuroplasticity, which is the creation of new connections in your brain at your neurons, or the neurogenesis, which is the creation of new neurons, or angiogenesis, which is the creation of new blood vessels. Physical activity can as well reduce inflammation at the level of your brain. And so given that physical activity is so good for you, why not give it as a form of treatment after having a concussion? And this was the question that we had in our lab. It was to understand better the relationship between early reintroduction of physical activity within 7 days post-injury following an acute pediatric concussion and the development of persistent post-concussive symptoms. So we really here wanted to see, well, when can a child return to play, return to sport, return to physical activity, and see if they actually do return to physical activity quite early on after their concussion. Was that going to have negative repercussion on their quality of life, negative repercussion on their symptoms at 4 weeks? And so from 2013 to 2015, in 9 Canadian pediatric hospitals, we collected data from thousands of children who had sustained a concussion, and over 3,000 participants were enrolled and followed for 12 weeks, where we assessed their symptoms and various other characteristics. And it's with this study that we decided to look into the comparativeness effect of returning to physical activity within 7 days after having your concussion, compared to those that had not returned to physical activity within that 7-day period after having their concussion. And so we found that resuming physical activity within 7 days post-injury was actually associated with a lower risk of having persistent post-concussive symptoms at 4 weeks. And so those that did start physical activity within 7 days of their concussion had a 24.6% risk of developing persistent post-concussive symptoms at 4 weeks, compared compared to those that had not resumed physical activity within 7 days, their risk was much higher. They had a 43.5% risk of persistent post-concussive symptoms at 4 weeks. And so active physical rehabilitation seems very important. And given that this was more of an observational study, a randomized clinical trial was needed to confirm these findings. And this is where I introduce the PCARE study. The PCARE study is Pediatric Concussion Assessment of Rest and Exertion. And this is a clinical trial that we did at CHEO and at 2 other sites in Ontario, so Sick Kids and London, to investigate whether early reintroduction of non-contact physical activity at 72 hours post-injury reduced the degree of symptom burden at 2 weeks following an acute concussion. And we wanted to compare this with usual care. That back then, usual care was a stepwise resumption of activity only once fully asymptomatic. So essentially, what we did is we randomized the kids that were coming into the ED with an acute concussion. We randomized them to 2 different groups. One was the treatment group, which was physical activity, where they needed to resume it gradually. And the other group was these kids needed to rest until asymptomatic. And after they were asymptomatic, they could do gradual return to physical activity. Our full sample size, we actually just completed this study. And so our full sample size was in the end 456 participants. And I was able to generate preliminary results for this presentation. And so if we look at the far left of the overall results, we see that symptom load differences, so that's their symptom at 2 weeks, we see that there's actually no differences between both groups. However, as we can see, those randomized in the early physical activity group have actually lower symptoms, so have less symptoms at 2 weeks compared to those that were randomized to rest until asymptomatic and only afterwards progress to physical activity. And interestingly, when we look at the graphs that are on the right side, we've decided to separate participants into risk scores of developing persistent post-concussive symptoms at 4 weeks, and how we had previously developed in previous research an algorithm that we could generate based on their characteristic from the ED, so based on their presentation characteristics. And so we find that those that are at lower risk of developing persistent post-concussive symptoms, they seem to benefit actually the most from returning to physical activity compared to the other risks group, so the medium risk and the high risk. And when we look at the high risk, interestingly, these are the patients or participants that are at higher risk of developing persistent post-concussive symptoms at 4 weeks, and they too seem to benefit of early physical activity after having a concussion. And so since these studies, and especially since the first study I spoke to you about, the one that was from 5P, rest for the guidelines have actually changed. So the guidelines have actually changed, and they've changed since May 2017. And the guidelines now state that that you need to rest for 1 to 2 days after a concussion. And even if you are symptomatic, you can return to your normal routine, and you can start a gradual return to physical activity. And so you can do physical and thinking activities as long as they do not make symptoms worse, bring on new symptoms, increase the risk of fall or hit to the head or body that could cause another concussion, or increase the risk for another concussion. And before any child or adolescent return to play on a game, so return to full contact sports or higher risk activities, the child needs to be cleared by his physician and needs to have returned to full time in school. So if we go back to those 6 things you should know about a concussion, the last point is that it is essential for optimal recovery to rest your mind and body, but only rest it for 1 and 2 days. And afterwards, you can progressively return to your normal activities and return to physical activity. So in summary, children that return to physical activity within 7 days have a lower risk of developing persistent post-concussive symptoms, and early non-contact activity at 72 hours post-injury, even if symptomatic, is safe and does not increase symptom burden. And so child and adolescents, this is just a really important reminder that adolescents and children, if they do play contact sports, they need to be cleared by their physician before returning to a game, because that could be very dangerous and could be fatal. Lastly, in case you want to have more information on concussion, we have we just launched last year the Living Guidelines for Diagnosing and Managing Pediatric Concussion, and there is a lot of information about how to manage concussions, and how to return to sports and how to progressively return to physical activity, something that hopefully we will get the chance to discuss during the question period. Thank you.
Thank you, Dr. Ledoux, for a great talk. And I'm sure there's a lot of questions, but those questions will be answered at the end for the panel discussion. So you can put your questions in the Q&A box on the bottom of your screen. And again, Natasha Hollywood will lead the panel discussion. So it's a pleasure to introduce our next speaker, Dr. Natalia Jaworska, who is a professor at the University of Ottawa, and she's also the director of the Clinical Electrophysiology Unit at the Royal Institute of Mental Health Research, and she's a member of the University of Ottawa Brain and Mind Research Institute. So welcome, Dr. Jaworska.
Thank you so much, Ruth. I'm just going to share my screen, hopefully relatively smoothly. Et voila. All right. So I'm going to be discussing the benefits of cardio exercise in depressed youth. And I think very quickly, I'd just like to provide a super quick definition of terms. So cardio is really the form of exercise that makes you sweat. So that's what I'm referring to in the context of this particular exercise, because there's many types of exercises. We can do yoga, we can do gentle walking, all of which have well-known benefits, but in the context of my work, this is really what I'm focusing on. So let's see if we can minimize this so you guys can see that better. Perfect. Unfortunately, I think we're all quite well acquainted with the concept of major depressive disorder. And that's probably because a lot of people experience this either personally or from loved ones, or have somebody who has struggled with major depressive disorder or simply depression. Now, it's perfectly normal to experience ups and downs in life. I mean, currently, a lot of us are not feeling particularly great. We've been stuck in our houses. We haven't seen loved ones, et cetera, et cetera. But depression is really different in that it becomes quite debilitating and really interferes with our daily functioning. And it's characterized by negative emotions, but also accompanying physiological and behavioral effects. So sleep disturbances, eating pattern disturbances, just a complete fatigue can all be characteristic features of depression. Unfortunately, it is rather prevalent, affecting approximately 10 to 15% of that population, with a really high burden of disease, meaning that it actually impacts a lot of people financially and has quite pronounced societal consequences in addition to the personal ones. About 8.2% of Canadian youth, and by youth I espouse this broader definition of youth encompassing 15 to 24-year-olds, report having a mood disorder. So a mood disorder is one of the categories where depression fits in, and it tends to be more prevalent in females than males. And unfortunately, depression really does tend to rear its ugly head in adolescence. But what clinicians and researchers have been doing historically is really treating depression in youth exactly the same way as they do in depressed adults, which might not be really the most appropriate strategy, because if you think about it, a lot of the research has been carried out in adult patients. So for instance, Prozac, which is a really commonly prescribed antidepressant, was all tested on 18 and up individuals. However, we don't really know what impact they have on youth. And actually, there was some research that came to light that there might be some side effect profiles that are actually a little bit different in teenagers. And really, why we're so concerned about timely and effective interventions is to not only take care of the depression in our teens as they're suffering from it, but this might also minimize the reoccurrence and more severe episodes that occur later in life. So we really want to equip youth with tools that may prevent subsequent, much more debilitating episodes. And it has been proposed that exercise may actually be a viable treatment alternative. Now, we all kind of intuitively know, and Andrée-Anne made mention of this, and as did Dr. Slack, that exercise generally makes us feel good once we get past, oh my goodness, this is so uncomfortable. And there's actually quite a bit of research to support that exercise, especially long-term aerobic exercise. So this I'm sort of using interchangeably with cardio. It's basically exercise that uses oxygen by your muscles, and again, makes you sweat. We've shown that this has mood elevating effects. Also, these mood elevating effects occur in depressed middle-aged and older adults. Now, there is some work showing that supervised, generally moderate to high intensity exercise, and this cardio exercise is promising and acceptable as a potential antidepressant strategy in youth. And some of the trickling evidence really shows that it's feasible, it's relatively cost effective, but most of all, it's actually helpful. Now, as Andrée-Anne already alluded to, there's many things that occur within the body and our brain when we engage in regular exercise. And essentially what occurs is there's an increase in neurotrophic factors, and I like to refer to them as neuron-loving molecules, because they literally kind of bathe your brain in a manner that really promotes healthy neurons, which is the primary cell within your brain. Exercise is also known to modulate both serotonin and norepinephrine, which are chemicals that are involved in cognition and mood. And in fact, the vast majority of antidepressants work on serotonin and norepinephrine. It also increases hypothalamic pituitary adrenal axis regulation, which is just a fancy way of saying our stress axis. And it also induces reductions in inflammation. And we know that inflammation can be quite neurotoxic, so bad for our brains. And altogether, this can result in new neurons, increased or altered connections between neurons, and also alterations in brain vasculature. Now, two regions that have been really the focus of what occurs with exercise on the brain is the hippocampus, which is shown right here, as well as the prefrontal cortex. Now, the hippocampus is involved in memory formation and also in emotional memory formation. And the prefrontal cortex is sort of our executive control mechanism. And both of these structures are very highly implicated in the context of depression as well. So it's kind of interesting that exercise influences the structure of these particular regions as well as their activity. And we also know that there's quite consistent alterations in these structures in the context of depression. Now, the youth brain is sort of unique, and this uniqueness may be particularly important when we are considering what exercise does to the brains of youth. And the 2 points that I would like to highlight is that both pruning, so trimming of neuronal connections, but also strengthening of neuronal connections, so we can call it refinement, that continues into late adolescence and early 20s, which is why I typically espouse this definition of youth that goes up until the middle 20s. And what we know is that the prefrontal cortex, so that region that I just previously showed, That continues well into our 20s, but the same is true of limbic features. So structures such as the hippocampus and amygdala, all of which are involved in emotional regulation, they too continue developing into the later teens. So the prefrontal cortex keeps on developing a little bit later, but these regions are also under continuous development throughout adolescence. But really, one of the main gaps that we have as researchers, and sort of where clinicians approach us and say, hey, how are we supposed to prescribe exercise? Because we really don't know certain things. And one of the major things that we do not know is, does exercise intensity matter? So if I go for a 10-minute walk, or if I go for a really intense 10-minute run, does that mean anything? Does that do anything? Also, do different symptoms of depression get differentially altered by exercise? And, do some individuals benefit more than others? Because much like other forms of intervention, certain things work for some people, but maybe not so much for others. And of course, I'm interested in the neural effects, but we will not discuss them, but do know that I am studying them. So I'm just going to highlight the work from two pilot studies, one in Calgary that I did and one in Ottawa, which unfortunately got interrupted, but I'll show you the preliminary results that I currently have. So for the Calgary cohort, we looked at a total of 12 patients, and they were 18 to 24 years of age. They were not medicated. And we got these poor kids to exercise 3 times per week for 12 weeks for 30 minutes, including also a cool down and a warm-up period. And we pushed them pretty hard. So we had a certain target heart rate that we wanted them to attain. And basically, this corresponds to high intensity exercise. And what we found was that there was indeed a gradual reduction of their depressive symptomatology throughout the 12-week period, which is exactly what we would have expected. And it actually hovered at around 50% reductions, which is basically comparable to what we see with certain pharmacotherapies and talk therapies. Now, adherence, so they actually came in and did the exercise, was pretty darn good. 80% is actually something that I was pretty impressed with. And their compliance, so actually doing the exercise at the intensity that we wanted them to do, was also quite good. So that at least suggests that this might be actually viable and feasible. Now, when we looked at their VO2 max measure, which is essentially a metric of cardiovascular fitness, which is something that we want to improve with aerobic exercise, that too increased. What I found actually kind of the most interesting was that the time that these individuals spent in their target heart rate zone, so exercising at the intensity that we prescribed, that was actually associated with the extent of their anxiety symptom decreases. So suggesting that there might be a link between adherence to a protocol and sort of the effectiveness of the intervention. Now, when I present to you some of the work from our current cohort, which is taking place in Ottawa, what we really wanted to do in this work is look at comparing medium versus high intensity exercise on depression and depression associated symptoms. So again, we tortured these poor souls with 3 times per week, 30 minutes each for 12 weeks. And we used a slightly broader age range in that we included 16 to 24 individuals, and they were randomized to a moderate aerobic intensity or a high aerobic intensity. And this time we kind of brought them up to that high intensity over a longer period of time. So again, these results are really quite preliminary, but what I'm showing in this graph is that overall, so without subdividing it into the medium and high intensity groups, we saw a decrease in depression symptoms, we saw a decrease in anxiety symptoms, and we actually saw a decrease in impairment, so day-to-day functional impairment, which is actually a really important metric that typically isn't looked at in a lot of the research. What I thought was also kind of cool was when we looked at their self-esteem and mastery, so having a sense of control over one's life, that too increased. So that's extremely hopeful to me as a researcher and to our patients. When we looked at their physical measures, they actually just kind of showed exactly what you would expect. So slight decreases in BMI, and then increase in cardiovascular fitness is sort of best illustrated here. Now, what I find actually extremely hopeful is, unfortunately, a common aspect of depression is also suicidal ideation, so suicidal thoughts. And both suicidal thoughts and the intensity of those thoughts, they decreased pre to post intervention. Now, I'm not showing you the data, but you're going to have to take my word for it or not. Absolute decreases in many of these depression-related symptoms appear to be greater in the high versus moderate intensity exercise group, but the N is very, very small. So I'm trying very hard not to be excited by these, but this is exactly what I kind of would be expecting. And again, our adherence and dropout were actually quite good in that. Adherence was quite high. Dropout was a little bit more than I had expected, but it typically occurred in the first week or so. So the youth who kind of stuck with it definitely stuck with it for the long haul, and those who basically were like, we maybe can't commit to this, they generally dropped out earlier, and we referred them to different resources. So really the take home of this work is that there does seem to be a dose effect, and this actually is consistent with other works, in that higher intensity exercise and greater changes in that cardiovascular fitness measure do appear to be more associated with clinical symptom decreases, although moderate intensity exercise also does show beneficial effects. We also found that generally supervised exercise of a longer duration is likely better than short-term exercise. And I mean, the reason for this may have to do with the fact that it takes some time for these biological effects to take place, but also psychological effects. So training oneself to have a schedule, adherence to a commitment, all of that are psychological benefits that are sort of secondary to exercise. I should point out that I'm not claiming that exercise is a panacea, and it might not be for everybody, but it seems like a very, very promising adjunct or accompanying treatment to our antidepressant treatment arsenal. And the lingering questions that I'm currently studying is what happens to the brain, and can we see some pro-cognitive effects? So we actually are looking at cognition in these youth. Generally, cognition impairments are rather subtle, but we are interested in exploring them. So I think we'll take questions at the very end, but I would like to remind everyone, just to be very kind, we know that exercise is hard work, and even though I'm making a claim that high intensity exercise is really great for you, I think I should also underscore that any exercise is fantastic, and especially during COVID. So that is it for me.
All right. Well, thank you so much, Dr. Jaworska. That was great. And again, we'll save the questions at the end. Just submit the questions in the Q&A box. So now it's a pleasure to introduce our last speaker, Dr. Amy Hsu, who is an assistant professor in the Faculty of Medicine, University of Ottawa, and she's an investigator at the Briere Research Institute and also a member of the University of Ottawa Brain and Mind Research Institute. So thank you for being with us today, Dr. Hsu.
Hello, good evening, everyone. I am going to attempt to share my screen. We're all working with new technologies here, so please bear with me for a second. All right, perfect. I believe you can see my screen now. So good evening again, everybody. Thank you so much for joining us for this event. It's my pleasure to be able to join this excellent panel here today to talk about the role of cardiovascular risk factors in various health outcomes, and specifically my talk will focus on sort of a late life health issue, a late life health outcome, which is dementia. So when I give a talk about brain health, and this is a question I often pose to the audience. So when we talk about brain health, what is the first thing that comes to your mind? Or when we talk about brain exercise, for a lot of us, when we talk about brain health or brain exercises, we often think about cognitive gains. We think about puzzles such as the crossword puzzle. We think about maybe gaining a new skill, maybe learning a new language. So we think a lot about how do we stimulate ourselves cognitively. But what I'm here to, and I think all the panelists here are here to do, is to convince you to think about the linkage between your physical health with your brain health. So the reason why I think, especially when we're talking about dementia, that we need to focus on physical health is that actually a large proportion of dementia cases are actually linked to modifiable risk factors. So a recently released report by the Lancet Commission has identified 12 potentially modifiable risk factors that account for at least 40% of the incident dementia cases worldwide. So what this means is that when the researchers had looked at individuals with each of these risk factors, and they looked at their relative risk of developing dementia, 40% of these new cases could be tied to one of these risk factors, which means that a large proportion of these cases could actually be avoided or potentially delayed by addressing one of these earlier on in life. So as some of as the other speakers had already alluded to early on, some of these risk factors include looking at traumatic brain injury, potentially around midlife, looking at other socio-demographic factors that influences your well-being in general, but also psychological well-being around mid and late life. So including looking at your predisposition or a diagnosis of depression, which could also link to social isolation, another risk factor that you see here. And of course, physical inactivity, which is what we're talking about here today. So this, you can see from this diagram, physical inactivity alone has been found to be associated to about 2% of the incident dementia cases. But what's also important is to think about this on a higher level in terms of what's the value of physical activity or the risk of physical inactivity on other aspects of health that also contributes to your risk of developing dementia. For example, it's linked to hypertension, other cardiovascular diseases. So before we jump into the linkage about cardiovascular risk factors and dementia, here are just some statistics on dementia in Canada. So as of 2014, there are approximately over 400,000 Canadians over the age of 65 with a diagnosis of dementia. So that represents roughly 7% of the population over the age of 65. As you can see, the proportion or the prevalence of dementia increases with age, which means that by the time the average Canadian reaches the age of 85, 1 in 4 Canadians over the age of 85 is likely to have a diagnosis of dementia. And what that means in terms of the incident case, which is the new cases that's diagnosed or identified each year, is that approximately each year we see about 76,000 new cases of dementia in our population, or equivalent to about 14 cases per 1,000 older Canadians over the age of 65. And there are changes over time. The proportion of new cases that are identified each year hasn't really changed by that much. There's some fluctuations. That's also partly tied to how the data is captured and when dementia is diagnosed. One of the challenges with the identification or diagnosis of dementia is that it's a syndrome. So there's an accumulation of symptoms over time. And often for individuals with dementia, especially in the earlier stages, so when you have a person has a mild cognitive impairment, potentially even towards a more advanced stage of mild cognitive impairment, they might not be diagnosed with dementia right away. And so if the signs and symptoms are not recognized, they're not formally diagnosed by a physician until much later on, or more advanced in their disease state. So that's why I think over time, we haven't seen that much change in incidence, because it is actually quite difficult to capture, although there are tests out there that would allow clinicians to actually make formal diagnosis. But once diagnosed, what's important is that we actually see with the population aging, there's an increasing proportion of people living with dementia in our society. And contrary to a lot of other diseases, we don't often think about dementia as a life-limiting disease. But in fact, in the research that we've done, looking at individuals with a diagnosis of dementia in Ontario, so this is a graph based on approximately 140,000 Ontarians who have a diagnosis of dementia. approximately 50% of them will actually die within 5 years. So it is actually a life-limiting disease. And if you compared it to cancer statistics, the survival from cancer, the average survival, 5-year survival from cancer is around 65%. And when you look at this graph, the 5-year survival from dementia is just under 50%. So while for a lot of us, when we think about cancer, you think about the impact it has on your life expectancy and the potential challenges that a person might have living with cancer, even when they're in a remission period, a lot of people don't think about the implications of dementia and what this means in terms of your overall health and what it might mean in terms of your need for supports later on in life and what types of services that could actually help you to continue to live independently in the home. And so a lot of the research I do actually use health administrative data. Basically, this is data collected routinely through your interaction with our healthcare system. So every single Ontarian who is eligible and receive healthcare services through OHIP, that data is actually collected. So every single interaction that you have with a healthcare system, that data is collected and then sent to the Ministry of Health. And it's put together and linked at the individual level in a data warehouse that's accessible to researchers. So I work with administrative data where we can essentially follow a person from birth to death. If they were born in Ontario, they spent their entire life in the province and receiving services in the province. So over a course of their lifetime, we can capture every single interaction with the healthcare system. And what we've done here was we identify individual with the physician diagnosed dementia in Ontario between the years 2010 and 2012. And we follow them over time to look at their healthcare use as well as their healthcare outcome. And what we found, as I showed in the earlier graph, is that approximately 50% of individuals who are identified as an incident case or newly identified dementia case, around 50% of them actually die within 5 years. And of those who are diagnosed, 50% will actually end up needing long-term care or being placed in a nursing home over the 5-year time frames from their diagnosis. And among those who remain in the community and survive beyond 5 years, many of them continue to live with significant limitations in their cognitive as well as physical function and capacity. And so many of them actually end up requiring long-term home care support. So when we think about dementia, it's not just a disease, it's not just a syndrome, it's the fact that you're living with a condition that also would require substantial support. And on top of that, this is not a single comorbidity that you're living with. And in fact, when we look at the cardiovascular comorbidities among Ontarians living with dementia, so again, this is looking at the entire population, 150,000 Ontarians diagnosed with dementia. We see that 85% of this population actually have a diagnosis of hypertension. Approximately 60 to 65% have a diagnosis of coronary artery disease. On top of that, there's diabetes, congestive heart failure, and atrial fibrillation or arrhythmia. So individuals living with dementia is not living with a single set of conditions that they're trying to balance, but also multiple cardiovascular comorbidities. So associated with these comorbidities is, of course, medication management. So as a person ages, this also presents another challenge in terms of not just managing dementia, but also managing your cardiovascular comorbidities. Which is why it's so important to think about, when we're thinking about brain health, we also have to think about the physical health, because maintaining your high level of physical activity or staying engaged in physical activity not only has an impact on dementia, but it has an impact on some of the precursors to dementia, including what we talked about today, looking at depression and also looking at cardiovascular comorbidities. And so again, this once again illustrates that, individual living with dementia is not living with a single condition or a single comorbidity. Approximately 50% actually live with 3 or more cardiovascular conditions concurrently. And what's interesting is that we know that women tend to have longer life expectancy than men. So in fact, because dementia is linked to aging, approximately 2/3 of the cases of individuals with dementia in Canada actually attribute to women. So majority of the cases of individuals with dementia are actually women over the age of 65. But what's really interesting is that when we look at the history of your cardiovascular events that could occur, so from the time, the earliest onset, one of the first signs where, one of the first indication that, there is something that potentially could increase your risk of dementia is a diagnosis of hypertension. As you saw in the earlier graph, 85% of those living with dementia have a diagnosis of hypertension. That's actually one of the first triggers that a lot of clinicians can start paying attention to in terms of thinking about the longer term outcomes for someone diagnosed with hypertension. And when we look at that history, hypertension is not only the first event that comes up, but in terms of the progression of events, the timing between hypertension and dementia is approximately 14 years in both men and women. And so although some of these other cardiovascular events happen at different frequency or different proportions over time, and they happen at different time points, so in terms of the age of diagnosis, we do know that there's a substantial amount of time where intervention could be introduced, especially when the first trigger, so something like a diagnosis of hypertension or diabetes, which is also highly prevalent in this population, is identified in an individual. So from the population perspective, these are sort of indication where we could say, when we look at intervention that we could introduce to the broader population to try to reduce the risk of dementia, to prevent or potentially delay the onset, these are populations that we can target our interventions to. And as I mentioned, the data set that I use is administrative data collected at the provincial level. So every time you use your health card, it's collected, it's transferred to this provincial data warehouse called ICES, or the Institute for Clinical Evaluation. That data is then taken by researchers to conduct all types of investigations and research, looking at various aspects of health, including looking at mental health, looking at health of youth in our population, and of course, other diseases and populations. So I'm part of a research team called Project Big Life. And what our team specializes in is developing clinical or personalized health tools that help to inform decisions around health as well as healthcare use. So we take this population level data and we develop a tool that helps you to make better decisions about your health and show and demonstrate to you each of the actions that you take. So anything that's related to your diet, lifestyle, other behaviors, as well as the impact of specific diseases, how these various these factors will interact and how it contributes to the onset of potential diseases and how it might impact your life expectancy. And so part of Project Big Life team, we have a suite of tools that one of the most popular ones that we get on our website is actually the life expectancy calculator. And under diseases, we have a number of tools targeting diabetes, targeting cardiovascular disease, and of course, dementia. We also have tools that helps you evaluate the quality of your diet. We have a dietary calculator. And we also have a set of health care planning tool for individuals who are older, who are thinking about their risk for needing long-term care or their risk for needing home care and potentially end-of-life care. So if you're curious, I encourage you to visit our website, which is ProjectBigLife.ca, and you'll find some of these tools here. Now, the dementia tool is actually under development and it will be released later this year. But what I will show you is actually a quick demonstration, or actually some illustration showing you what one of the other tools that we have looks like. So this is a heart attack or stroke calculator, our cardiovascular disease calculator. It's actually used actively by the Heart and Stroke Institute in offering recommendations and predictions about life expectancy of individuals with CVDs. And so when you log onto the website, you'll see that this is sort of the user interface. You can find out more information about the calculator by clicking on read the science section, and the calculator takes less than 5 minutes to complete. And so you go through a set of questions asking about your age, your sex, your chronic conditions that you might have, your lifestyle, as well as other behavioral risk factors. And at the end, you'll get a report where it will actually estimate your risk of potentially experiencing a heart attack or a stroke within the next 5 years. And we try to interpret this in a number of different ways so that our user could actually try to understand their risk from different perspectives. So, when we're looking at proportions or probability, 1% or 0.7% might be difficult to think about in terms of, okay, what does this mean in the broader context of how much impact it might have? So another way of thinking about it is that 1 in 100 people who have a similar response as you will likely have experienced a heart attack or stroke over the next 5 years. But we also try to present it in a way that helps you to compare your health to the health of an average Canadian as well as a healthy Canadian. So I actually did this calculation based on someone who is 55, who is a non-smoker, engages in regular exercise, not high intensity, but regular exercise. And they have a fairly balanced diet. So, they have regular intakes of fruits and vegetables. And what you see is that compared to a healthy Canadian, their heart age is actually slightly older than their actual age, which means that there are aspects of their health or their lifestyle and behavior that they can improve on. So this is just a fun way for us to try to help individual users think about how you can improve your health. And then we'll also identify some of the main risk factors that contributes to your results, your estimated score on the website. So if you're curious, I encourage you to take a look at the calculator this evening or when you have time to play with the tools that we have available. So coming back to this first slide that I had showed early on about the potentially modifiable risk factor and the challenges in actually looking at the direct link between physical activity and dementia. What I want to point out is that, as I mentioned, physical activity actually has multiple linkages to other precursors of dementia. So including depression, including, as we heard about earlier, it has impact on individual with a traumatic brain injury. It has an impact on your risk for hypertension, which is another risk factor for dementia. It has an impact on obesity, has an impact on other cardiovascular conditions. And so there are many, many benefits associated with physical inactivity, but that also makes it more difficult for us to try to identify how much exercise do we actually need to do to actually reduce our risk of dementia. And so now more and more researchers are moving into this area. And in fact, when you compare the results from the same report that was released 3 years ago, you can see the advancement of science in this area. Whereas 3 years ago, the existing research that was linking individual modifiable risk factor to dementia identified that potentially 35% of the new cases could be attributed to one of these potentially modifiable risk factors. But now we're looking at 40% because we're getting a better understanding of how these various individual variables actually contribute to your risk. And in fact, there are new variables that are being identified each year with new and emerging research, including some of the early evidence or emerging evidence looking at the association between air pollution and dementia. Traumatic brain injury is an emerging area as well. And of course, other lifestyle and health behaviors, including consumption of alcohol and looking at your sleep patterns, for example, and their individual impact on your risk of developing dementia. And another area of growth or emerging research that I'm really interested in is the use of new technology to try to capture data that will actually help us to get a better understanding of physical activity and health. And ultimately, how does this impact your risk for dementia? As you know, a lot of these existing research are based on observational studies. So, we ask individuals, we survey individuals and ask them, how many times did you exercise in the past week or the past month? So a lot of times these are ballpark estimates, and sometimes people forget, to keep track of their actual hours. So there's some imprecision in the existing research. So more and more researchers are thinking about how do we automate the process? How do we actually try to capture more precise data and potentially using one of these wearable devices that not only gives us information on your levels of activity, but also many other biometric inputs. So including looking at your sleep patterns and, for example, your heart rate. And this is a simple example that I actually pulled. So this is personal health information. I pulled this off of my Fitbit application. And I'm just highlighting to you that, you know, over the past month or so, I've been engaged in grant writing. As you can see, you know, with the stresses that comes with a busy grant writing season, my resting heart rate was significantly higher than my average. And towards the end of the grant writing season, you see also my level of physical activity has increased over time. But you also see that my resting heart rate has actually improved. So this is just a simple illustration to show the benefits and the potential for leveraging existing technology to continue to advance research in this area. So that concludes my presentation, and I'll turn this back to you, Ruth, and Natasha for questions.
All right, that's great. Thank you, Dr. Xu. And all the speakers for great talks tonight. And now I'll hand it over to Natasha Hollywood, our manager, who will lead the panel discussion.
Thank you very much, Dr. Slack. We will have maybe the panelists just open up their cameras for this part of the session. We've received some great questions, so I'll just kind of go ahead. I think this would be for Dr. Ledoux. Did uncomplicated versus complicated pediatrics and TBI make any difference in number or duration of post-concussive symptoms?
So you can hear me? So hi, thank you for the question. So first of all our concussion that we have, that we recruit for our studies are all uncomplicated mild traumatic brain injury. So that means we don't have any patients that have neuroimaging anomalies or skull fractures, for instance, that are recruited in our studies. But if we look a bit at research and what research indicates us between complicated, uncomplicated concussions and their impact on post-concussive symptoms, the research is very it seems to start indicating that there's not much differences between both, and both are as high risk to developing persistent post-concussive symptoms, depending on certain personal characteristics and depending on their level of activities. So right now, the research is indicating to us that you're not more at risk of developing persistent post-concussive symptoms if you have complicated mild traumatic brain injury.
Thank you. Dr. Jaworska, this one's for you. Can you give some examples of what high intensity physical activities the youth in the studies would have participated in?
Yeah, so it's an excellent question. We actually get a lot of questions about what the heck we actually do with these kids. So high intensity exercises would be something like jogging or running or using the rowing machine. So those are probably the most concrete examples. But one thing that I should make mention is, you know, the success of having these kids adhere to some of the programs is also giving them quite a bit of flexibility. So giving them the choice in how they do what they do and rotating between exercises is actually something that has been suggested as a strategy that makes adherence and dropout, you know, less of an issue. But I should also mention that, you know, high intensity or moderate intensity is actually very relative, because if you have very good cardiovascular fitness, you know, you might be running a freaking marathon and you're doing great, and that's not really all that high intensity for you. For some other kids that we recruit who have never exercised, you know, initially a very gentle walk might constitute for them high intensity exercise, because what we do is we tailor it to their own heart rate. So that, I don't know if I pointed that out. So it can be sort of anything, but generally higher intensity will include something like jogging or rowing, stuff like that.
Thank you. Dr. Xu, this one's for you. How much exercise do we need to reduce the risk of developing dementia?
Yeah, so I think actually it builds really nicely on what Natalia just said. I think, it really varies by age. There's a lot of variation by ethnicity as well. So when you look at different population, the recommendation is different. And actually, that's an area of research that I'm engaged in right now in terms of looking at what's the recommendation for older adult population. But a lot of the research that have been done, so looking at individuals between, the ages of 40 to 70, what research has indicated is that when you're looking at moderate to vigorous activity of around 2.5 hours per week, which is sort of the recommended guidelines for, mid-age to older adults, that actually has a reduction of about, 20 to 30% in your risk of dementia. And I think it's a little bit different when we talk about exercise for an older adult because, not many older adults will be running marathons, not expecting a lot of 65-year-olds to be running marathons. And so when you think about the range of activities, it could be light cycling, anything that breaks the sweat. You talk about brisk walking, dancing is a fun one that a lot of older adults are engaged in.
Thank you. So the next question, probably for Dr. Ledoux, how does the concussion research relate to exercise in adults?
So concussion research is more prominent in pediatric right now than in adults. But the guidelines are clear that for adults as well, returning to physical activity after having a concussion is good. I just want to remind everyone, and this is very important, that when I say return to physical activity, 48 hours after having a concussion, I'm not saying slapping your skates on and going back on the ice rink to play hockey right away. It's really progressive return to physical activity. So, after 48 hours, the first thing would be to go for a walk for 15 minutes to try to get readjusted to physical activity slowly until you're feeling better. But so in adults, the guidelines, the new Berlin guidelines are specific for adults and pediatrics, and they do state that you are able to return to physical activity after 2 days of rest.
And this is another general question to the panel. What sort of exercises were considered moderate high intensity in the studies?
So the moderate intensity, at least in the work that we do, is actually quite similar in terms of what the participants do. It's just that they don't push themselves. So if they're, for instance, jogging on a treadmill, what we might do is increase their incline if it's more high intensity, or decrease it for moderate intensity. A brisk walk can also do the trick. Again, we're trying to keep them in a pretty specific heart range in order to actually test our hypothesis as to whether there is a difference between medium and high, which can sometimes be a little bit artificial and kind of annoying to our participants. Full disclosure, they're wearing, watches that will beep at them when they're going above or below a certain exercise intensity. So it's actually kind of interesting seeing these kids progress and their cardiovascular fitness get better, by 11 weeks. And they're like, yeah, but I want to go for like a hardcore run. And it's like, well, yeah, but that's not your group. So it can vary, but generally, we would say moderate intensity would be kind of the same things, but done at a slightly reduced pace.
Dr. Xu, this one's for you. You have mentioned physical health conditions linked to dementia. Does neurodegenerative diseases such as PD and neurodevelopmental conditions such as ASD also increase the risk? Would physical exercise lower the risk significantly for these populations? Thanks.
Yeah, I think that's an excellent question. And I think that's an area where we're starting to build these causal models, trying to understand how the various diseases are linked. I think there's actually, this morning I was engaged in a conversation about the linkage between depression and dementia, right? And whether depression is just part of dementia, where it's a symptom that's expressed, as an underlying as a condition that underlines, just neurodegeneration overall. And so there's more and more research in this area, and we're starting to gain a better understanding. But there's definitely evidence that point to sort of commonality in terms of risk factor for a lot of these neurodegenerative diseases.
Thank you. Is exercise beneficial once you have persistent post-concussive symptoms? Dr. Ledoux.
So yes, it is definitely good. So that this is one line that has changed a lot in management. And as soon as you have persistent post-concussive symptoms, number one is we try to prevent persistent post-concussive symptoms. But if you end up having persistent post-concussive symptom, doing physical activity is good. It is still an excellent treatment. But if you do have persistent post-concussive symptoms, I do recommend you seeing as well your physician and a clinical team that's composed of a physiotherapist, a mental health worker, such as a social worker or psychologists, and OTs as well, that can help you really understand your symptoms and manage your symptoms and help you return to physical activity as well. But physical activity is incredibly important if you're in the acute, subacute stage, and as well in the chronic phase of a concussion.
Has there been any studies in Tai Chi as an activity in reducing dementia or factors related to onset of dementia, like reducing hypertension? It's a popular activity when talking about ethnicity, cultural activity.
Yeah, that's an excellent question. So I think a lot of observational studies, as I mentioned, are very difficult to establish actual association or direct linkages between that activity and the outcome in the population. So some of these lighter activities like Tai Chi and yoga, the effect is not quite as dramatic as what we see in sort of the moderate to vigorous activities. But of course, individuals who are able and willing to engage in moderate to vigorous activity are also more likely to be individuals who tend to have a more balanced diet. They're more physically active in general, fewer comorbidities. So I think it's a very complex area of research, and we're starting to untangle these. But I think any exercise, as Natalia mentioned earlier, any exercise is good. I think it is difficult to say whether Tai Chi or specific activities are linked to that. But I think just staying active and staying engaged is an excellent start.
Thank you. The next one would be last night, one of the speakers suggested that exercise to the point of exhaustion was not good for people with Parkinson's disease. What is the case with people with concussion or other at-risk groups?
So I guess I should be taking this one. So yes, so the speaker is right. Physical activity until exhaustion after having concussion is not recommended right now, at least in the pediatric world. Right now, we are still studying that to see what is the highest intensity of physical activity someone can do without, and for it to still being safe. This is our next sub-study that we will be doing with that study, with the PCARE study, the one that I presented. But no, you're right. So until the body hits exhaustion, what happens is, instead of being helpful and healing your brain, it's actually being, it has a negative effect, and it is really not helping healing your brain if you do physical activity until exhaustion. More research is definitely needed in that respect.
So for probably Dr. Ledoux again, is the concussion rest period recommended the same for adults now, only 1 to 2 days?
Exactly. So for adults and kids, it's 1 to 2 days rest. I did see, I think, another question that related to the same thing that I might try to answer at the same time. So it's 1 to 2 days of rest. When we say rest here, it's not necessarily to go into a dark room and close yourself in the room and not do anything. I mean, it's still fine to do your small normal routine of let's say cleaning the dishes. Just don't overdo it. So for adults and kids, it's 1 to 2 days, and afterwards you progressively return to your daily routine. So if it's going back to work, it's trying to progressively return return to a full-time workload of school as well, and getting back to your physical activities that you have.
Dr. Jaworska, this one's for you. Why did you choose to go with supervised exercises versus at-home exercise?
Right. I love that question because we get that a lot. The main reason is because adherence is pretty darn difficult when you are depressed and motivation is already an issue to keep to a regimen by yourself. So kind of study after study, at least in the context of depression, which is characterized by, motivational issues, has really shown that the accountability piece of coming in to the gym and exercising basically results in much better adherence to the intervention than otherwise would be observed. Now, there's obviously caveats to that. Occasionally, when our youth get very kind of comfortable with a routine, we do permit them to exercise at home if they can't make it in. So of course you have to be flexible, and we give them the heart rate monitors so that we can schedule that. Part of it also is a safety issue because we are actually recruiting individuals who don't typically engage in exercise. We want to make sure that they're safe and supported. Some also kind of come in and might be suicidal. I mean, this is just the nature, unfortunately, of the disorder. And that's sort of at least to check for us to ensure that these kids are doing okay. Because if they're having a really, really, really rough day, or we observe that their symptoms are going down, it's our role to also steer them to appropriate resources. We work with the psychiatrist. So it's safety and adherence.
Thank you. This was early on when Dr. Ledoux was actually presenting. So great info, youth concussions. As a coach and parent of teen daughter who had concussion from Riyadh last year, how widely known is this new research? Protocols amongst family docs and other health professionals say 72 hours to start activity. It was not what was recommended 10 months ago.
Yeah, so John Willett makes a good point here. So what's happening here, so the guidelines have actually changed since May 2017, which are called the Berlin consensus guidelines. And so it's a bit how the information is getting out to physician, and it's really up to the physician in the end and coaches to make their research to make sure that they are handling a concussion correctly and they are giving the proper management protocols to follow. So our guidelines that we have here in Ontario, which are called the ONF, so Ontario Neurotrauma Foundation Guidelines in Pediatrics, were modified in September 2019. So just that so yeah, 2019. And so these guidelines are known. We are making the best that we can to do KT, so to make knowledge and translations of them, and knowledge and translation of research. And so it is, you raise a good point. We are trying to do our best to get that information out to physician. But it's been since May 2017 that the 48-hour clause has been added to the guidelines.
Great. We had a few comments saying thank you much. Thank you, the three of you, for your presentations and your research. I just want to say that before probably asking the last question, so we have time for the conclusion. Dr. Ledoux, for those 2 first days after concussion, which is considered rest, it used to be a dark room, but how has this now changed? How should kids be advised to increase activity once they have post-concussion symptoms?
So, okay, so am I on? Yes. So once they have post-concussion symptoms, so here the question, I can answer it both ways because post-concussion symptoms is different than persistent post-concussion symptoms. And so, no, as I previously stated, number one, the kids do not need to go into a dark room after having a concussion. It's 1 of 2 days of rest. There has been several studies since that have discussed that just prolonged rest after having a concussion is not good and can increase actually your anxiety, depression, and physiological deconditioning as well to your brain. And so this is why the guidelines have changed, and now we state 1 to 2 days of rest. We still want the child to take a deep breath for 1 to 2 days, and then afterwards it is okay to progressively return to physical activity. So when we say post-concussion symptoms, so this might be considered in the acute and subacute phase, so after 72 48 hours, so from 48 hours till you reach the 4-week term, then this you can progressively return to physical activity. And this means returned. I'm not sure if I could still share a screen, but if I can share, if you permit me to share something with you, I would share this right here. And the guidelines that we have do stipulate really how to return to physical activity. So we always start by light aerobic exercise, so walking, swimming, stationary cycling, for instance. And then if this this exercise or this type of exercise is not increasing symptoms to the point that they become intolerable, then it is okay. You can go to the next stage. And so next stage would be sports specific exercise, for instance, skating drills. If the kid is a hockey player, or just running drill if the child plays soccer, for instance. It's always important to remember to have no head impact activities. And then afterwards, if the symptoms are tolerable, then the kid can move on to stage 4, which is non-contact drills, so progress to complex training drills where it gets a bit more intense. And then just a reminder that you would need to be fully cleared by your physician before going to full contact practice. And so this would be a return to physical activity in the subacute phase. But once you have persistent post-concussive symptoms at 4 weeks and on, then this is kind of similar. If you have a lot of symptoms that are intolerable, it's just to gradually return to physical activity, gradually return to these activities. You can take these same stages and apply them to you or to your routine. And I think the important point is that if physical activity makes your symptoms intolerable, then you're going too far with the physical activity, and just go back a stage or go back a bit, reduce a bit the intensity, and the next day you can try again. So I hope that answers your question. We'll stop sharing right now.
So that's great. So thanks a lot to all of our speakers and the audience participation in the question period, and we'll try to answer your questions online at a later time. I'd also like to thank our partner institutions for their collaboration. And tonight we highlighted the work from the CHIO, from the Royals Institute of Mental Health Research, and the Elizabeth Briere Research Institute. So thanks very much. And also, if you would like to support research at the University of Ottawa Brain and Mind Research Institute, again, please go to the link on our website. The power for change is yours. And also, again, for more information and also answers to your questions, we'll post those on our website at a later time, and there'll be more events going on throughout the year. So I hope you can join us for tomorrow's event, which will be on advancing neuromuscular and ALS research in Canada. And thanks very much for being with us. Good night.